So just a little bit of background. Obviously, I think at this point we can say, all right, there's a place for mental health and pain care. There's a place for pain-focused psychotherapy. But really, why? Where did it come from? Well, I don't know if you all remember this, but back before the COVID-19 pandemic, there was kind of an epidemic in this country that was termed the chronic pain epidemic or the opioid epidemic. And a lot of that discussion kind of got pushed to the side during COVID, which was completely understandable. We had to deal with that first. But there was a war on opioids going on before then. And what happened for a lot of people during that time, there was a lot of policy change and a lot of legal changes that required physicians to make changes in the way that they prescribed. And some of those physicians kind of freaked out a little bit and may have the pendulum may have swung too far. And so a lot of people were either very quickly tapered down off their opioids or kind of pulled off their opioid medications altogether. And for a long time, many people were managing their pain through that mechanism. And so people were left with higher levels of pain than they were used to having and a lot of distress because it was happening very quickly for a lot of people. And they weren't sure how to cope with their pain or manage their pain without those medications. Um, and so there were a lot of people looking for other ways to cope with and manage their pain now that the kind of go-to mechanism of opioids may not have been available to them. And so pain-focused therapy really became big, in part due to that. It was big before, but it really kind of rose to the next level when this happened. The other reason is because pain is really a biopsychosocial issue, okay? It affects the individual physically, which I think we can kind of just intuitively understand, but it also affects people psychologically in terms of how they cope with it, how it affects them socially, how it affects their interactions within the family, their role at work, their role in society. And when all of those things are impacted, it can really affect somebody's sense of self or their mood and their ability to engage in treatments and follow medical recommendations and to engage in many of the self management strategies that are required for living with chronic pain. So it really does affect the whole person. And so, because of that, you need a treatment approach that's going to affect the whole person. So, we've been talking a little bit about the impact of chronic pain, and I think we can all agree that those impacts can be pretty profound when it comes to somebody's emotional state and their sense of self. The research supports this as well. The research pretty consistently supports the idea that people who have chronic pain often report kind of a loss of control. So they'll talk about feeling betrayed by their body or feeling like they don't have control over their life because now their pain or their body is dictating what they do and what they can and cannot do rather than them having a choice in the matter. And that can be really frustrating and difficult to deal with. People also talk about kind of an inability to function or a perceived kind of disability, meaning they're not able to participate in physical activities that may have once been easy for them, like no big deal at all, or that were really meaningful to them at some point in time. And so, because of that, obviously, that's going to be a challenge to cope with emotionally. And then finally, people talk about a loss of past self. I hear many, many people talk about, oh, that was me before the pain. And it's almost like they're mourning the death of someone, and that there's this really clear, defined cutoff between who they were before pain and who they were after pain. So all of those kind of changes in self-concept really can start to take its toll on people and lead to changes in how they think about things, which then leads to depression and anxiety and anger and decreased quality of life. And all of that is bad enough, but emotional distress can also contribute to and actually maintain pain, which creates a kind of vicious cycle that's very hard for people to get out of. Again, there's a whole talk on that, but just if we have that basic understanding that part of what we're managing in pain-focused therapies is this cycle between the physical and the emotional. So when we talk about pain-focused therapy, there are actually a lot of different options. The ones on the screen are the ones that are kind of most available at this time. There's also a newer approach that is kind of getting talked about a lot being pain reprocessing therapy, but it is such a new approach that I'm not going to broach that today. Most of the scholarly evidence thus far is actually in support of cognitive behavioral therapy and acceptance and commitment therapy. So that's really why we're here today. I will say that CBT in particular has long been considered to be kind of the gold standard of pain-focused therapy. It's been studied for, 4 decades, countless research articles, and everybody just kind of thinks when they're thinking about psychological interventions for chronic pain, they think CBT, CBT. And there's good reason for that. It's considered to be pretty efficacious across different ages and across different pain diagnoses. But I will say it doesn't work for everybody. And so in 2016, an article by Broderick was published. 2016, by the way, was a big year for pain research. So there's going to be a lot of citations from that year. But a study was published that said that people who have more interpersonal problems and also have comorbid pain or have interpersonal problems as a result of the pain don't benefit as much from cognitive behavioral therapy, which I find interesting. They also found that the extent to which the patient was invested in the treatment or believed in the treatment mattered, which, kind of makes sense. And then also that CBT tended to be more effective for people from, who were older and from more highly educated backgrounds. So again, not working for all. I will also say I don't have this on a slide here, but when you actually look at the meta-analyses for CBT for chronic pain, we see that the results are actually greater for specific types of chronic pain. So it's a really good option for fibromyalgia. It's a good option for arthritis. It's a good option for migraine, but those are the groups in where the evidence is the strongest. So if you don't fall into one of those groups, or if you are or somebody for whom CBT for chronic pain just doesn't seem to fit or doesn't seem to be working, the good news is that there's actually other options, and that's why we're here today, right? So ACT can be a really good option for people who don't do well with CBT, who've tried it and it didn't go so well, or for people who have really tried everything under the sun to manage their pain and have not yet to find any kind of reprieve from it. Additionally, there was an article published in 2021 by Campbell and colleagues, and they suggested that ACT actually might be more appropriate for older adults in particular. And the reason for that is because older adults tend to have more sites of chronic pain, but also more comorbid medical issues. And the nice thing about ACT, as we're going to talk about, is that it's transdiagnostic, meaning that it really doesn't matter what the presenting problem is. You're still going to use similar or the same techniques and interventions, and it's a very flexible approach. And so you don't always have to just focus on the pain. You can focus on the pain and the other medical conditions and the other things that are going on in the person's life. And so it just kind of makes sense when we're talking about those types of populations. So it is worth noting that while ACT specific to chronic pain is a relatively newer intervention compared to CBT, ACT as a psychological intervention has actually been around for decades, like starting back in the 80s, and it has been very well researched. So Stephen Hayes, who is considered to be the founder of ACT, started doing research on relational frame theory, which is really the foundation of ACT in the 80s, and then it kind of grew from there. And so there's really a ton of research to support the framework of ACT as a whole. Again, not going into that today. ACT for chronic pain, however, has been studied for about 17 or 18 years, okay, give or take. And the earliest study that I could find, and I've done a ton of research on this, the earliest study of ACT for chronic pain that I can find dates back to 2004, okay? So it's definitely a newer approach. And in the beginning, kind of around the early 2000s up to 2010, there really wasn't much research on it, I'm going to be honest. And you'll see that over time, the research started to grow and it started to become more recognized and have a better evidence base behind it. And now it is regarded as a pretty decent alternative to CBT.